So we are here for the West Coast Fellows Conference. This is actually iteration number 23, believe it or not, which is awesome. And today I'm really excited to have John with us from the University of Arizona. John did a lot of his training at the University of Toronto, and he did a fellowship in spine in Toronto as well, and also got his PhD in the electrophysiology of spinal cord injury, which will be very, I think, relative to our discussion on spine trauma today. He then did another fellowship at the Neurologic Institute, practiced in Canada, founded the Canadian Spine Society some time ago, and now is the director of a spine director program in Arizona. So really excited to have you here, John, and thank you so much for being with us and for sharing things with our fellows. And I'm going to stop my screen share, and then you should be able to share yours.
All right. Well, hopefully we're going to have a little better time of it this time. And I think we've troubleshot all the technical difficulties before. So with that, you should be able to see my screen. Is that good, honey?
Yeah, we're good, John.
So I want to spend a bit of time talking about the utility of MRI and spine trauma. And we're a level 1 trauma center here, and trauma is near and dear to my heart. And I've seen some trends lately that are kind of bothering me a bit. Maybe we'll get time to talk about those in the end, but residents and medical students and even some faculty are starting to talk about getting an MRI to see whether the ligaments are injured or not in trauma patients. And I'm going to hopefully provide some background on that and maybe generate some discussion. But to set the stage, I don't have anything to disclose, except I live in a beautiful place like most of you do as well. But I think we should consider where our classification schemes came from. This is the timeline for classifications of the thoracic lumbar spine. And it was in the late 1930s that the first system came out. There was some more in the late 40s. Holdsworth had a 2-column model that was in the early 60s. Kelly and Whitesides also went on with a 2-column model. But it was in the 70s and 80s that CT scan and MRI became available. And despite that, we didn't see them, the MRI in particular, creep in to the classification schemes until later. At the same time MRI was coming out, Denny had the 3-column system. McAfee proposed a mechanistic system. Ferguson Allen had a mechanistic system. And the Magarel AO system came in the mid-90s at the same time as Punjabi and White and Paul McCormick. In the late 2000s, Vaccaro brought in the TLIC system, and that's the first time that MRI was used to contribute to a grading scheme for thoracolumbar trauma. There's been a modification to the AO since then, but the state of the art pretty much remains since what we had at 2010. If we look at cervical spine trauma, it's a much less crowded timeline. Holdsworth in the early 60s, Allen in the early 80s, Harris around the same time. White and Punjabi, again, the biomechanic gurus, proposed a 2-column model. And for the fellows and residents, be careful. There's been no description of a 3-column model in cervical spine trauma at all. There's a 3-column model in thoracolumbar, but there's a 2-column model in the cervical spine. So don't, in your exams, start talking about 3-column model for C-spine injury. Anderson came up with a 4-column model. And again, once Alex hit the picture with the SLIC system, which again brought in MRI. So with these 2 papers published in Spine, first in 2005 about thoracolumbar injuries, and with the cervical spine injury classification published in 2007, I take full responsibility for these papers, but I also want to point out the original intent of bringing the MRI into the classification system was to help surgeons that were uncertain with the posterior ligamentous complex and wanted to know, were equivocal about whether it was disrupted or intact. So the MRI was included to give them the option of calling it indeterminate. It wasn't intended for disrupted. So with that, 20 years later, I'm sorry to have to report that the utility of MRI is still controversial. And if you'll bear with me, I'll try and illustrate that. I want to go through 3 papers, the major hitters for MR trauma and MR imaging in trauma. There's a paper published in 2016 by a group from Nassau University Medical Center in East Meadow, New York. And it was a 7-year retrospective review from 2008 to 2015. Single center. It included trauma registry patients, including CT and MR C-spine imaging for any reason. So that could be minor trauma without instability. It could be major trauma with instability. There were 241 patients with a mean age of 44, 60% male, 46% injured in motor vehicle accidents. 153 of them had negative CTs. So here's the setup. We've got a negative CT, 153 patients that then went on for MRI. Of those, 3 patients, 2%, had a positive MRI and a normal neurologic exam. And I'm bringing this in because this is also something that guides us in our decision of stability and instability. So out of 153, only 2% with normal CTs had a positive MRI. None of these patients were treated by surgery, indicating the utility of MRI to be questionable. Second paper, 2018, it's Malhotra. He's a very prominent radiologist, and it's a 3-year retrospective review from 2013 to 2015 at a single center in Yale. He's still there, still practicing, still writing. The inclusion criteria were blunt cervical trauma, including falls. CT was used along with MR imaging, and a positive MRI was included as positive if there was signal change in the cord, if there was signal change in the disc, if there was signal change in the bone, if there was signal change in the ligament or muscle. So anything positive on the MRI was positive. The real controversial issue in my mind is that they graded their stability on the Denny 3-column model. Now, as you know, this is an MRI study, right? The Denny 3-column model is based on bony anatomy and bony relationships. So they extrapolated this to include ligaments. And if they had signal change in 2 columns, then they considered it to be unstable, not been validated, and probably not worthwhile. But they had 1,080 patients with a mean age of 57, 55% were male, 44% had a ground level fall. So there's a lot of minor trauma going on here. 712 or 60% had a negative CT. So again, in our trauma centers, if the CT is negative, that often is a stopping point for us. But here in their case, 712 had a negative CT, of which 149, so 21%, based on their criteria, had a positive MRI. Of those, 138 or 93% were judged to be stable, and 7% were judged to be unstable or potentially unstable based on this 3-column model. 3 out of 11 had surgery. So when you pare this down from 1,080 patients to 3, again, you're dealing with not only very small numbers, but questionable indications. Why did they have surgery in the first place, right? How was stability really judged other than MRI? And there's no indication of that. So the other paper is kind of a no-brainer, I think. It's published in 2021 by Sutherland. It had a lot of numbers. 4-year retrospective review, 2013 to 2016 at the University of South Florida. Again, CT as well as MRI used in their imaging. Traumatic C-spine injury. Patients were unexaminable due to loss of consciousness or distracting injury, and had an abnormal neurological exam or even just neck tenderness. The inclusion criteria were a positive CT and or MRI exclusively, could be one or the other, fracture, ligamentous injury, contusion, hematoma, disc injury. So all kind of comers based on radiology report. 805 patients. CT was compared to MRI with a sensitivity of 50% and a specificity of 77%. And you could argue it should be the other way around, that MRI should be compared to CT with respect to sensitivity and specificity, but it wasn't. Stability in this study was not assessed, so ultimately I've wasted your time. It was not clinically relevant because they didn't even attempt to look at stability. It was really just comparing findings between the 2 modalities of imaging. So if we don't know about the utility from the literature, what do we know? Well, I want to go through 5, what I think are 5 important points, and these are for the residents and the fellows. For the attendings, I apologize if this seems like common sense. But if you're going to make judgments based on an MRI, these are 5 things you need to remember about ligaments. Number 1, here on the left, I want to remind you about the 3-dimensional anatomy of the ligamentum flavum and even the anterior longitudinal ligament. The point of number 1 is that, remember, ligaments are dense collagenous structures that hold bone together, and they have a 3-dimensional structure, including length, width, or thickness, and height. Point number 1. There's the posterior longitudinal. Beautiful, beautiful pictures, beautiful studies. Those are Netter pictures, by the way. Point number 2, ligaments restrict movement between the bones and therefore are a primary determinant of biomechanical properties of the spine and the biomechanical principles that teach us about stability. Ligaments work in concert. Remember that. There's not just one ligament in this motion segment. There are several ligaments. And so that's what determines how our spine moves and how it responds to trauma. Point number 3, some ligaments are stronger than others. On this diagram, you'll see on this axis, on the vertical axis, are the newtons required to cause a particular ligament to fail. 0 ligaments all the way up to 400. Here on this axis, we have anterior longitudinal ligament, posterior longitudinal ligament, ligamentum flavum, the capsular facet ligaments, interspinous ligaments, and the supraspinous ligament. And you can see through cervical, thoracic, and lumbar, there's a heterogeneity to the strength that the ligaments have before they fail. The strongest ligament in our bodies, not surprisingly, the anterior longitudinal ligament in the spine, that is. And in the cervical spine, you can see the capsular ligaments are consistently about the same throughout cervical, thoracic, and lumbar, but particularly in the cervical spine, the capsular ligaments, facet ligaments, are very important. They're the strongest ligaments. When the facet ligaments fail on a C-spine X-ray, we pay attention to that, right? That's important. So that this kind of gives you the background. And what that means is, therefore, failure of some ligaments is going to be more important in determining stability or instability compared to others. If the ligamentum flavum fails in the cervical spine, but the capsular ligaments are intact, we throw away the ligamentum flavum in laminectomies. We tend not to pay too much attention to that. All right, point number 4, ligaments fail in distraction. Ligaments do not fail in compression. They compress in compression. They do not fail typically in translation. They strip themselves off the bone and they tend to go where the other bone's going. So you get a gap across the ligament where there becomes an empty space. Ligaments fail in distraction. Remember that. Finally, as I mentioned earlier, ligaments work in concert. So even in high velocity impact trauma, the spine will initially try to move first within its biomechanical constraints until the ligament or bone fails, and then it will exceed its biomechanical constraints. But failure, therefore, happens in predictable patterns affecting groups of ligaments. So what does that mean? Well, consider in a hyperextension injury, in order to damage the posterior longitudinal ligament, first, you're going to have to disrupt the anterior longitudinal ligament. Basic biomechanics. Let's take the opposite example. In a hyperflexion injury, in order to damage the capsular ligaments, first, you're going to have to disrupt the interspinous ligament. Then you're going to have to disrupt the ligamentum flavum. Then, once the capsular ligaments are gone, in order for those facets to jump, you're probably going to have to disconnect the posterior longitudinal ligament as well. So that's what I mean. When you're looking at this, you're thinking biomechanically. We're not thinking like a radiologist in 2 dimensions. We're thinking in 3 dimensions. So getting back to the original question then, what really is the utility of MRI in trauma? Well, because of all of this smoke and mirrors, we tried to look at this from a different way here at the University of Arizona. We looked at a prospective consecutive cohort study. And what that means is that these patients were entered as they came in a registry with a specific research hypothesis in mind. This was from July 2020 to June of 2022. The inclusion criteria were any patients with C-spine trauma who were cooperative and had a normal CT scan, then went on to have positive or abnormal MR imaging, and in which spine surgery, us, then got consulted because the patients were potentially unstable. Now, normal CT scan was not always normal by the radiologists. They usually interpret degenerative changes and can misinterpret it. So normal meant to the spine service. The CT scan looked normal to us. Positive MRI imaging was determined by the radiologist, not by the spine service. So that was the inclusion criteria. We got 33 patients over 2 years that met these strict inclusion criteria. 13 of them had motor vehicle accidents, 11 had falls, 3 were assaulted, 3 were pedestrian accidents hit by motor vehicles, and 2 were bicycle accidents. 1 was a motorcycle accident. On the MRI report, the verbiage that was used was partial tear in 10 of the patients, disruption in 7 of the patients, interrupted in 4 of the patients, distraction in 3 of the patients, attenuation in 1 of them, and strain in 1 of them. These are the terms that the radiologists use to describe basically signal change in the ligaments. If we looked at what ligaments were actually called out by the radiologist, this is the percent incidence across the entire cohort. And 50%, it won't surprise you, of the ligamentous signal changes were happening in the interspinous ligament. 20% were happening in the ligamentum flavum. There were 10% in the anterior longitudinal ligament, about 5% in the posterior longitudinal ligament, and in the facet capsules as well. And I'm going to drill down into this a little more deeper, because the problem with this is all single ligament involvement. There were some multiple ligament involvements, and I'll come back to that in a minute. But let me give you an example. This is one of the cases where the radiologist called her neck unstable. 22-year-old female involved in a motor vehicle accident. It was a highway speed rollover. And her GCS at the time at initial admission was 13. She was fast positive, so the ultrasound showed some fluid collection in the abdomen. She went for a stat OR lap. And the CT of the C-spine was interpreted as normal by us. As you can imagine, the radiologists interpret this as loss of normal cervical lordosis, which is fine. If you look at the facets, on both sides, you can see facet alignment is fine, no perching, no jump facets. But certainly loss of lordosis, which we see in many cervical spine trauma patients, and maybe a little bit of positional coronal angulation, but nothing to me or the rest of the team that indicated instability. Trauma team won't clear her C-spine, so they ordered an MRI to help clear the C-spine. The report came back, discontinuity of the ligamentum flavum at the levels of C3 to T1, concerning for ligamentous tear with associated interspinous ligamentous edema, most prominent at C4-5 and C5-6. Well, of course, this caller stays on, trauma team calls the spine team, and we have to look at this. This is what they found. This is the MRI, and this is a T2 weighted image, and you can begin to see some signal change in the interspinous areas that they were referring to here. But the real thing that the radiologist got bent out of shape about was what they thought to be the black stripe sign. This is the black stripe, which represents the ligamentum flavum, and they called it to be discontinuous at every single level of the cervical spine. Here's the axial view, and when you look at it, there's the ligamentum flavum in black. Here's the posterior longitudinal ligament here, and this is where it's intact, right? It's coming from this area. And here's where they called the ligamentum flavum to be disrupted. Well, most of us would not expect the ligament flavum to fail in any other way other than side to side across the axial plane of the spine. Radiologists don't think that way. Instead, they would think that a toothpick hole in the ligamentum flavum potentially represents ligamentum flavum, which makes no biomechanical sense at all. Here's another example. Here's where the black stripe's intact. Here's where the black stripe's disrupted, potentially unstable. I don't think so. Here are the flexion extension views we got 2 days later when she woke up enough to be cooperative, and not surprisingly, no evidence of ligamentous failure. Once again, I want to point out that to get to that area, you're going to have to have the ligamentum flavum fail, you're going to start to see signal change in all of these ligaments, because for one ligament to fail, there's going to be stress and strain placed on all of these. What the radiologist also did not look at, and here you can see it, this is the parasagittal image. I hope you can pick out the facet joints here. Maybe there's some interspinous signal change here, but there's absolutely no signal change within the facet joints. And as I mentioned, for us as spine surgeons, they're a major determinant. Here they are on the other side, facet joints look clean. They're a major determinant of stability. So 33 patients stayed, all 33 patients in our study stayed in extended full spine precautions. All 33 of them had normal flexion and extension x-rays once we got the chance to get them up and get them going. The collar was removed successfully in all 33 patients, and surgery happened in absolutely none of them. And this is a single institution. At that time, we were the only level 1 trauma center in southwestern Arizona. None of these patients over that 2-year span of study accrual ever came back and ever had surgery at our institution. None of them returned, and none of them had surgery. I want to share with you a different case of mine just to make a point. This is a 26-year-old male in a motor vehicle accident, GCS3 at the scene, intubated, transferred by helicopter. He withdraws his arms, no leg movement. And here's his CT scan, not his MRI. This is his CT scan. And it doesn't take a spine surgeon to recognize that when you look at a translational fracture pattern like this, here versus here, and then you look at distraction happening back here between the posterior elements, you would predict as a spine surgeon that all of the ligaments back here are going to be disrupted. And you don't need an MRI to show you that. Indeed, intraoperatively, you can see all of those ligaments are disrupted. So in conclusion, I wanted to really hit home the message that ligament integrity is an important determinant of spinal stability. Ligaments have 3 dimensions. They are not all created equal. They work in unison, not in isolation. They fail in distraction. And bony alignment remains the gold standard of ligamentous integrity. Please, residents, do not say you're going to get an MRI to determine whether the ligaments are disrupted or not. Signal change does not equal ligament disruption. I think in conclusion, this is an opportunity for care, exercising caution in interpreting and wording reports. Radiologists are not clinicians. They can talk about signal change. They should be very careful about talking about instability. Disruption, instability leads to unnecessary tests. And we're seeing here, now that we've got another level 1 trauma center on board, we're seeing potential cases of unnecessary surgery based on MRI reports alone. In my experience, ED, MDs, emergency room physicians, trauma surgeons, and I think, unfortunately, even 20 to 30% of spine surgeons are not comfortable or potentially incapable of interpreting MRI imaging in spinal trauma. The current utility of MR in spine trauma, in my opinion, is exactly here, is signal change in evaluating the spinal cord and neurologic deficits. I want to thank Maurizio Avila, who was my chief resident, who helped us do this study and execute it over 2 years. And he ultimately went on to do a fellowship with Jens Chapman and is now in practice in St. Louis, Missouri. And that's it. Thank you. I'm gonna stop sharing.
Thanks, John. That was awesome, man. I really appreciate it. Well, we have some time for questions. It's getting pretty close to 7, but we've got a few minutes. Does anybody in the group have a question for Dr. Hurlbert?
It's pretty intimidating.
So, John, do you think should we go back to more? What are your thoughts on, re-looking at like algorithms of how we actually evaluate these trauma patients? Is that kind of your thought process, more using more dynamic testing? And I mean, obviously in the case of the neurologic injury, things get a lot easier, but in the case of those that are neuro intact, that have potential, like a Telix force, right? Those are really the ones that we're talking about. And so, like, are you thinking more going back to dynamic testing, ambulating, radiographic data, flexion extension films, that kind of thing? Or what's your recommendation other than, going to the imaging side?
Well, I think that's a great question, Greg, because one of the points I hope that came out is that the number of patients, in 2 years, we see over 1,000 C-spine trauma patients, most of which are fine, right? So the number of patients that really fall into this category we're talking about are very small. So I'm not sure it's worth changing algorithms, but I do think it's important how we interpret the algorithms. And so I don't think MRI should be a trauma team tool or a radiology tool. I think it should be a spine surgeon tool when you're consulted to see a patient and you're not sure if you want to get an MRI and follow the algorithm and then put that patient into an indeterminate, fine. But do it based on the biomechanical principles I'm describing, not based on one-dimensional or two-dimensional interpretations of a single ligament. In an area this big, when the ligamentum flavum in an AP view should fail over an area this big, right? Keep those in mind. Radiologists don't get that. And then if you're still unsure, for me as a spine surgeon, I'm not going to take that TLX 4 to the OR. I'm going to do flexion extension views. And it's true we don't have good clinical evidence for that. And the reason is it's like evoked potentials. The sensitivity and specificity is hard to get because the number of patients is so small. So the biomechanical studies that determine the sensitivity and specificity of our x-rays were actually cadaveric studies where you can see the ligaments fail. They're much more sensitive than x-rays. But in my mind, you've got a question on the MRI, get flexion extension views. And if they're fine, you're good to go.
Really great points, John. Well, we are
Yeah,
at
totally agree. Oh, you're good.
We're at the 7 o'clock time point, so we'll bring it to an end. I did just want to remind folks about the Bridging the Gap conference here in San Diego. It's July 19th and 20th. If there are any fellows on the call that want more information about the meeting or how they can maybe get some funding for it, please feel free to email me or Greg. And look forward to the upcoming West Coast Fellows Conference schedule. We've got a couple of great speakers, Dr. Pauly, Dr. Bay, Dr. Shirazi. So thanks everybody for being here. Have a great week and a great weekend, and we'll talk again soon.
Thanks again, John.
Thanks, Annie.
Thank you.
Thanks, John. Talk soon, guys.